Congestive heart failure, CHF, and atrial fibrillation, Afib, are both chronic conditions that affect the heart, but they impact it in different ways. CHF is characterized by the heart's inability to pump blood effectively, which can lead to symptoms such as shortness of breath, fatigue, and swelling in the legs and ankles. In contrast, Afib involves an irregular and often rapid heart rate, which may cause palpitations, dizziness, and an increased risk of stroke. Treatment for both conditions varies. It commonly includes lifestyle changes, medications, and potentially procedures or surgery to manage symptoms and slow disease progression. Risk factors for CHF and Afib include high blood pressure, coronary artery disease, and diabetes, as well as lifestyle choices such as smoking and excessive alcohol consumption. Here are detailed aspects of congestive heart failure and atrial fibrillation for those seeking a deeper understanding. Affected systems: circulatory efficiency versus electrical rhythm. Congestive heart failure, CHF, and atrial fibrillation, Afib, are two distinct cardiovascular conditions that often coexist, complicating each other's management. CHF is characterized by the heart's inability to pump blood efficiently, leading to fluid buildup in tissues and organs. This can cause shortness of breath, fatigue, and edema. In contrast, Afib involves an irregular and often rapid heartbeat due to abnormal electrical activity in the atria. While CHF primarily affects the mechanical function of the heart, Afib disrupts its electrical rhythm, increasing the risk of stroke and heart failure. Both conditions share risk factors like hypertension and coronary artery disease, yet each requires targeted treatment strategies. CHF often necessitates the use of diuretics and ACE inhibitors to reduce fluid overload and improve cardiac output, whereas Afib may require anticoagulants to prevent clots and medication or procedures to restore normal heart rhythm. Distinguishing between the two is essential for effective management, as their co-occurrence demands an integrated approach to treatment that addresses both the circulatory inefficiency and the electrical disturbance within the heart. Primary symptoms: fluid accumulation versus heart palpitations. Congestive heart failure, CHF, and atrial fibrillation, Afib, frequently coexist due to their interrelated pathophysiology, where structural heart changes predispose patients to both conditions. A distinguishing symptom of CHF is the accumulation of fluid, leading to edema and shortness of breath, a reflection of the heart's diminished ability to pump blood effectively. In contrast, Afib primarily manifests with irregular heartbeats and palpitations, stemming from the chaotic electrical activity in the heart's atria. Although both can share symptoms like fatigue and exercise intolerance, attention to fluid accumulation versus palpitations helps differentiate the primary disease driving the patient's presentation. However, thorough evaluation is essential, as one condition can mask or worsen the other, complicating the clinical picture. Onset of disease: progressive versus intermittent. Congestive heart failure, CHF, typically manifests as a progressive condition where the heart's ability to pump blood efficiently declines over time, leading to symptoms such as shortness of breath, fatigue, and fluid retention. As the disease advances, these symptoms progressively worsen. In contrast, atrial fibrillation, Afib, a type of arrhythmia, can present with sudden, intermittent episodes of rapid, irregular heart rate. While sometimes Afib can become more persistent, the onset is often characterized by episodic events that may not immediately signal an underlying chronic deterioration, unlike the steady progression seen in CHF. Importantly, these two conditions can coexist, compounding cardiovascular risks and complicating the clinical picture. Underlying causes: pump failure versus conduction disorder. Congestive heart failure, CHF, and atrial fibrillation often intertwine clinically, yet they originate from distinct pathophysiological mechanisms. CHF is primarily a syndrome where the heart's pumping efficiency is compromised. Causes could range from myocardial infarction, damaging heart muscle, to chronic hypertension, making it harder for the heart to pump blood. In contrast, Afib stems from irregular electrical activity, leading to an erratic and sometimes rapid heartbeat. This conduction disorder can be provoked by a variety of factors, including high blood pressure, heart valve disease, and excessive alcohol use. Interestingly, while each condition can occur independently, they frequently coexist. CF can lead to AFib due to structural and functional changes in the heart, and conversely, AFib can exacerbate CHF by diminishing cardiac output and precipitating heart failure exacerbations. The interplay between these two entities necessitates a nuanced approach to treatment, where addressing one may positively influence the other. Typical interventions: diuretics and ventricular support versus rate control and anticoagulation. When considering treatments for congestive heart failure, CHF, versus atrial fibrillation, AFib, the goals and interventions differ significantly. For CHF, which is characterized by the heart's inability to pump blood efficiently, diuretics are often prescribed to reduce fluid overload, and therapies to support ventricular function such as ACE inhibitors or beta blockers may be utilized. On the other hand, AFib, a condition denoted by an irregular and often rapid heart rate, typically requires rate control medication like beta blockers or calcium channel blockers to manage heart rhythm, and anticoagulants like warfarin to prevent blood clots due to the increased risk of stroke. The strategic approach to these conditions must be tailored to their unique pathophysiological challenges to optimize outcomes for patients.